and the next presentation by Dr. Bratis, who will try to give us a combination of all images regarding the aortic valve pathology. Dr. Bratis.
Thank you very much. Let's move on with the imaging part. So we had the clinical examination, the clinical approach. Very well. So first, I'm in the difficult position of commenting on the BAV anatomy following Professor Anderson's talk, but I have to do that as well. Then see what are the available tools, what are the modalities that we have available in order to better assess in detail the congenital aortic valve disease, and finally see how these are implemented in clinical practice with a quick look on the existing guidelines. So when we discuss congenital aortic valve disease, mainly we talk about bicuspid aortic valve, while less frequently there are the forms of supravalvular and subaortic anomalies, as we heard a bit earlier. And BAV is a relatively common condition affecting 1% of the general population with a mainly a strong male and Caucasian predominance. And a genetic component is suggested, given that 10% of patients with BAV, with isolated valve disease, will have first-degree relatives with the same condition, with similar presentation, anatomical abnormalities, while when this is combined with an aortopathy, this percentage can reach up to 20 and 30%. In terms of etiology, there is no definitive etiology identified, but we consider that this has to do with abnormal embryogenesis and organ formation. The characterization of BAV in terms of anatomy depends on the number of raphes and commissures, knowing that the vast majority of cases will present with at least one raphe and a fusion of the right and left coronary cusps, aortic valve disease cusps, aortic valve cusps. Now, the condition is frequently associated with other abnormalities, such as a shunt in the form of PDA and or VSD, coarctation, thoracic aorta, anomalies of the vessel wall, coarctation and obstruction in 50% of cases, and aberrant coronary arteries, coronary artery anomalies. Valve disease, of course, has to do with stenosis, regurgitation, or a mixed disease. We'll discuss this a bit in detail later on. And thoracic aorta disease, the aorta disease mainly has to do with dilatation that can progress to an aneurysm, and with acute complications, with a possibility, the risk of acute complications such as the dissection. Overall, when we discuss about BAV, we should think of BAV of a valvular aortopathy rather than of an isolated valve disease. In the same context of complications, we should add also consider always the risk of infective endocarditis, which is much more significant compared to the general population. Now, once we identify a patient with suspected or confirmed on the echocardiogram, confirmed BAV, what are the questions to address next in order to establish the diagnosis, risk stratify, and plan ahead our management, the treatment, or just monitoring one? First, we have to describe the anatomy of the valve, the number of raphes and commissures. Then the valve function. Is there any associated disease, stenosis, regurgitation, or mixed disease? Also, the effect of that on the heart function, the cardiac function, any remodeling or dysfunction. And also the aortic morphology and hemodynamics, any concomitant aortopathy. With this, we can assess, as we'll see later on, just after, we can have an estimation of the risk of progression, and then on the outcomes, so prognosis, risk of progression, and risk of endocarditis as well. In 1 in 3 patients, BAV presents with moderate to severe stenosis at the time of first diagnosis, knowing that 1 in 10 patients will reach a surgical level at a later stage. While regurgitation presents in 20 to 30% of cases, with a 5% of them being in need of an operation at a later stage as well. Now, we know from the existing evidence that the more RAFs we've got, the more significant the disease will be. So the severity of stenosis and regurgitation depends on the existence and number of RAFs. While data are conflicting with regards to the rate of progression, how fast, how rapid the progression to a significant disease will be, we cannot assess that just based on the initial anatomy of the aortic valve. Similarly, aortopathy is classified at different types of aortopathy with regards to the implementation, to the involvement of the initial aorta, the ascending part of, or the whole thoracic aorta, ascending and descending component. And there are a few interesting things to consider, a few interesting key points to consider when we discuss about aortopathy. So it is evident, it is present in 50% of young adults with a new diagnosis of BAV, but it is not linked to the severity of the disease, meaning that different or at least additional mechanisms other than the obvious mechanical aspect of that, the mechanical aspect of effect of valve disease on the vessel wall are involved. And we know that compared to the general population, there is a significant risk, a much higher risk for development of an aneurysm, which reaches up to 86%, a risk for surgery of 46%, and of dissection of 7%. Again, the number of RAFs is linked to the level, to the extent of the aortopathy. So the segments of the aorta that are involved and will present with dilatation have to do with the number of RAFs. What does this mean? That the number of RAFs are an indicator of valve disease and of aortopathy as well, of severity of the aortic disease of the aorta, the disease of the aorta as well. Some additional data. Based on these, we can tell that a fusion of the right-left cusp is linked to a dilatation of the ascending aorta, while the fusion of right and non-coronary cusp is mainly linked to aortic root dilatation anomaly. Although we can imagine that BAV means a higher need for an operation, either of the valve or the ascending aorta at some stage in the patient's life, overall the survival of those patient group is similar to the general population. And again, outcomes are linked to RAFI, just to highlight this message. Now, next, we have the impression on a clinical examination of valve disease, then we can demonstrate that with a baseline echocardiogram, and the next step is the evaluation of the disease, the severity, the accurate severity of estimation of the severity of the disease, any concomitant extravalvular consequences of that, such as the aortopathy, risk stratification, planning for any intervention, monitoring, and of course assessment of complications. These are the tests that we have that we'll consider in our clinical practice. It's the echocardiogram, the transthoracic one, which is the base, the wide base of this pyramid of examination, relies on transthoracic echocardiogram. It will inform on the valve disease severity. It will inform on the cardiac dimensions and function, any remodeling. And obviously, it's a safe and it's an easily accessible tool. It should be our first choice without question. Then, and for assessment of the valve as well, it's a dynamic real-time exam. It has a specific advantages, certain advantages compared to the other modalities. Whenever needed, when a detailed description, anatomical description of the valve is needed, especially when the question is about an intervention or operation, then there are additional tools such as the transesophageal one, 3D echo as well, that can provide additional important information in that direction. And there is a role, as we'll see later on as well, for cardiac CT and cardiac MRI. They are not the first line tools in this case, in valvular disease. They are quite important, however, and they have a complementary role that can determine the management of the patient. So, for example, when there are conflicting data, when the diagnosis is not certain based on the echocardiography, the advanced or the basic one, then there is a role, for example, in aortic stenosis for CT to assess for calcium scoring, which is both diagnostic but also has a strong predictive role in this context. And as discussed earlier, in cases where things are where data are not definitive for valve severity in the context of regurgitation, the MRI can provide accurate volumetrics. It's also the exam of choice. We'll discuss that a bit later on. The exam of choice for ejection fraction and dimensions assessment. Is it a matter of numbers solely? No, but they are still key components of our decision making, and sometimes, or quite frequently, we are in need of accurate numbers. Now, we should consider a cardiac CT whenever the aorta assessment is in question, and in particular in the acute scenarios, if there is a suspicion of complications, such as dissection. It has a rapid nature, and it has an excellent spatial resolution. It is the exam of choice in that clinical scenario. It can depict, and this is an advantage compared to magnetic resonance, it can demonstrate efficiently calcification of the valve. As we mentioned, this has a diagnostic prognostic role with different cutoffs in the context of BAV compared to tricuspid valve because calcification is intrinsic part of BAV from the early stages, so it's not linked to the severity of the disease in the same manner as in tricuspid valve disease. Still, there are cutoff levels that can guide us, both in terms of diagnosis and prognosis. We can assess for coronary disease and any grafts, and of course, plan for any intervention. TAV is part of BAV algorithm in nowadays. So whenever the discussion is about the choice of the appropriate treatment, surgical or interventional, there is a key role for cardiac CT in that context to inform about the accessibility to the aorta from an interventional point of view, then the degree of calcification, the anatomy of the aortic valve annulus as well, any chest deformity or scoliosis. Fine. Next. So, cardiac MR. Cardiac MR is a key exam in congenital heart disease in general, and in particular in bicuspid aortic valve assessment as well. It has specific advantages that are unique. It's safe, it's comprehensive. There is no use of radiation. A lot if not the majority of the sequences, do not require the use of contrast. Let's think of some scenarios, some patients with renal failure, patients with contrast allergies. They could have efficiently an MRI exam that could inform accurately without the use of radiation or a contrast agent. So we can have thorough assessment of the ventricular size, dimensions, and function. It is the test of choice of that. We can have accurate assessment of the aorta dimensions, but also the vessel wall anatomy at a 3D level as well, which means that I can choose specific part of the thorax and with consecutive slices depicted in a three-dimensional manner in a detailed and very accurate form. This could be part of surgical planning as well. This could be part of 3D modeling, as I heard earlier, 3D printing as well. There are studies, with the use of MRI, we can produce 3D models, printed models. But also get accurate two-dimensional and four-dimensional assessment of the flow at different level. I can choose in a three-dimensional manner any level inside the thorax and assess for the flow dynamics at that level, at that point. And get images like this one with information that exceeds just the volumetrics or the velocity, but also we provide information on shear stress, on other parameters that might inform from a prognostic point of view in the near future as well. This is the data. These are the images that I may acquire with the MRI. As I said, in the acute setting, in the case of suspicion of aortic dissection, MRI would not be my first choice. There is a role for CT there, as given its rapid nature. So the message is that MRI offers a comprehensive assessment of nearly all components of the cardiovascular system. And obviously, it has a central, a pivotal role in the assessment of congenital aortic valve disease as well. It offers answers, it replies to all the questions that we raised earlier during our first approach to the patient, to the new diagnosis of valve. Now, which test is the best? It's already answered several times this morning. The appropriate test tailored to the clinical question. There is no best test. It depends on what we are looking for, what we are missing in order to manage our patient in the best way. This will guide our choice, our selection of the next test. This will also help the patient avoid all the stress, the tiredness, the cost of having several tests without an obvious reason. So it's the clinical need, it's the information that we miss that will guide, that will help us choose the appropriate test. And quite often we'll be in need of more tests, but this is not a rule. It does not mean that we'll always be in need of an MRI or an echo. And this is clearly described also in our guidelines, as we'll see in the last few slides, although it is a matter of discussion. So it is a hard team, it is a teamwork, even the choice of the appropriate test and then the discussion of the results. So as mentioned earlier, this is reflected in our guidelines that the echo is in the base, is central to the assessment of valve disease, both in the context of aortic stenosis and of regurgitation, with the complementary role of the cross-sectional imaging. Also for what concerns monitoring, so there is an issue how frequently and with which modalities should I follow up a patient with congenital valve disease. Echo is central in that as well. Things are different when there is a concomitant aortopathy. There, we should think of cross-sectional imaging. It's obvious. We have a three-dimensional imaging of the whole thorax. So there is the advantages with cross-sectional imaging. If the question is on follow-up, longitudinal follow-up, this should be an MRI because of the lack of radiation, because of its safe nature, because we are not always in need of contrast unless we think of a complication or there are new findings that are not clear. So without the use of radiation or a contrast agent, we could follow up a patient, monitor him for years. But again, the final message is that the choice of the appropriate treatment, of the appropriate test, should be a matter of teamwork. I should have the opportunity to discuss with my imaging consultant which test I should choose based on my clinical needs, my clinical question. Thank you.
Thank you for this excellent review on the imaging of the aortic valve. And now the floor open for questions and comments. Professor Kalangos.
Okay. Yeah. Thank you very much, Dr. Bratis. As you mentioned, the most important problem with bicuspid aortic valve is also the associated dilatation of the ascending aorta or the aortic root. In adult population, there is a cutoff value. Many years ago, based on the guidelines, it was 5 centimeters. Above 5 centimeters, you have to intervene. Now it's 5.5 centimeters. But in children, there is no clear indication. For example, a child of 5 years old with a functional bicuspid valve, the diameter of the ascending aorta is 3.5. Do you intervene or not? This question is for the whole audience.
I guess it's for the audience, yes.
Yes. And what is the cutoff Z value then?
We don't use the cutoff Z scores. We strictly use the rapidness of how quickly the aortic root grows. So that's very important. And currently we stick to the 45 millimeters because we don't see the infants or small children. So they usually, the bicuspid aortic valve starts in the teenage. But we are slightly cautious, so we use the 45 and more than 5 millimeters per year on CT angio. So these are the... Sorry? Regardless age, yeah. I think that the rapidness of how quickly it's growing, it's very important. It should be...
I had a case on a yearly basis, there is an increase of 2 millimeters. But it started, at the age of 18 months. And each year, is adding this 2 millimeters. And it's a big question. Because there is,
That's a small child.
Yeah, it's now, it's 5 years old. 3.5, but 2 millimeters, and what to do?
Yeah, that would be the individual approach. Yeah. I mean, what is the absolute dimension in this?
Now it's 4.5 years old and 3.6.
Sorry?
The diameter is 3.6 centimeters.
3.6.
4.5 years old, 3.6.
Because the problem is, you will be obliged not to use a small diameter Dacron tube, and it will not grow. And then, you will create another problem.
Is there not
some involvement of the aortic root also, and it means you have to do a chiron because the bicuspid valve is functional. There is a trivial aortic regurgitation and a gradient of 10 millimeter of mercury.
So there's no stenosis, no regurg.
10 millimeter of mercury and trivial aortic regurgitation. Absolutely functional.
I think it's very rare in such a small child, 4 years.
What to do? Because there is a regular progression. And
I can't give you a number in this case.
Will beta blockers or ACE inhibitor help this not to accumulate in a very rapid way?
Yeah.
You know, since 18 months, he is under the beta blockers. Unfortunately, it didn't stop this progression of 2 millimeters on a yearly basis.
Probably increase the dose and add an ACE inhibitor.
I have never seen, the rupture in such a small child.
Yeah.
So difficult. Yes, beta blockers certainly.
What I think about peers in kids is 3.5.
Yeah.
3.5, I haven't heard about peers being used in pediatric populations. But if the valve is okay, and if you want just to prevent the rupture, 3.5 would be an option to put a mesh.
Yes, because in some cases of bicuspid aortic valve, this one was very well described. It was an article in the journal was medicine. There is a genetic predisposition. Because I remember, I had 2 twins. I was obliged to operate on them at the age of 2 years, both of them. The aortic suddenly, the diameter of the ascending aorta was, more than 6 centimeters at this age, imagine. But it's very difficult to discover also if there is, this genetic progression.
Are they Marfan?
No Marfan. We did, all the tests. And even, I sent the specimens I removed, to the histopathology, and there was nothing, in favor of Marfan syndrome or Ehlers-Danlos.
But you have the many others, they're asking mutations.
Yes,
Yeah.
Louis Dietz and other conditions.
So for your case, I would advise to contact Elena Chervy. She's our expert in aortopathy. She's collecting all children from United Kingdom, so she's very, very experienced.
Any other question on the imaging of the aortic valve?